Right. Viewers is not new. Some of the provinces already have their own viewers, and they have a sort of a investment which they've made. Okay, it's a bit like the fact that we have, we have landlines and telephones, which eventually will totally disappear. From what I understand, there will be no more landlines. But we could have had mobile technology apparently much, much earlier than we've had it. But the telecommunication companies had such a huge investment in all this copper running around that they weren't about to use that investment.
But,
anyway, go ahead.
but the viewer project, maybe he misunderstood me. I was talking about the radiology,
Why didn't they pick up?
Yeah, but that was a brand new project. DICOM is DICOM is DICOM.
Yeah.
And that was a brand new project.
Yeah.
There was nothing existing. There were all these packs existing, but you can
Yeah.
throw DICOM in. But I was very interested why they had gone with a completely different product and a completely different model
Yeah.
than what's going on in
Well,
Alberta.
Again, it's quite possible that BC wanted nothing to do with it because it was an Alberta-based effort. You gotta remember that too. There's a lot of competition between the provinces.
But
too.
they had this huge committee and they spent tons of money to develop this product, which actually I've just looked at
Yeah.
it, and it looks way better than
I know.
what we'd ended up with.
That's rational, that's logical. It's not Robin, you're being very rational and logical.
Oh, I know,
You
but
may
that's
not
what it's,
necessarily be political and emotional. Because that's a reality of our world. We do that all the time. We reinvent wheels all the time. Nothing to do with being rational and logical.
but that's what computerization should do. It should
Absolutely.
stop you from reinventing the wheel.
Absolutely, absolutely. Okay, we better get going because we're going to try to scan a number of countries and get a feel for what's happening around the world. Okay, the countries we're going to hope to try to cover today. If we don't make it, well, then you have all the material. Again, there's a lot of hidden slides that I'm not going to show, so we can just see the material. Yep.
Where did you get that slide from? Was it called something particular, or from one of the websites?
No, it's not on the website.
Oh, it's on the, okay, I'll stop looking.
I'm a firm believer in not doing things until afterwards.
Okay.
Because a couple of reasons. One is I literally changed the deck just before we came to class, made some changes. And secondly, I'm a real believer in the power of going over things twice. So you listen to it, you watch it, and then you see it again.
I was just spending some effort here looking through.
Okay, it's not there yet. So I'm not going to cover Canada, the US, or Denmark, since we're having separate classes on those, but I'll try to get an overview of the others. Okay? Now, I'm also not going to talk about the broad e-health agenda. Okay? This is going to be mainly focused around the EHR, which is just one facet of the broader application, as we said yesterday, or on Thursday, broader application of information and communications technologies in healthcare. And so it takes in a lot of other things. Takes in a lot of other things. This discussion is not going to touch very much on those. Okay? Just simply in the interest of time. Let's go to the whole course to international work. We can look at all of that. Okay, before we start, part of this is to try and get a feel for which country is perhaps leading the way, which country perhaps is more advanced, perhaps and can be considered sort of the gold standard of the day. That's very difficult to do. It's difficult to do for a number of reasons. Okay, I'll quickly go through some of the reasons why it's very hard to be able to say, well, where does Canada fit in the international spectrum? Very, very difficult question to answer. First of all, we have national strategies and we have regional strategies. Pretty well every country in the developed world has some form of national strategy. Some of them don't call them strategies, they call them plans. And some of them are quite old, they're 5 or 6 years old, others are more common. But most countries we can go and find documents as to what their strategy is. But we also have some very powerful regional strategies. So in our case, in our 13 jurisdictions, we could probably find 13 various strategies for the province. So Manitoba has a strategy, Saskatchewan has a strategy, Alberta has a strategy, and so on. Okay? And throughout the world, particularly in federated health systems, and when we talked about healthcare systems, we said most of them are federated. Dick this morning said that Singapore is a very private-oriented healthcare system. England is a very central one healthcare system for that country. Most of them are federated like Canada. So the regions, which we call provinces, in Spain they call theirs regions, equivalent to our provinces, and they call the areas within the region provinces, just the opposite of what we use. In other countries, Switzerland and Sweden, they call them counties, but it's a federated system where healthcare is devolved down to a provincial level. Okay? We can look at a variety of regional strategies. And the regional strategy, just as in our country, may or may not coincide directly with the national strategy. In some cases, the regional strategy is all there is. There is no national strategy. Okay, we'll see that when we go to Italy. Italy doesn't really have a national strategy. They got a couple of very good regional strategies, and they're making good progress. Another thing that's difficult, and this is perhaps in some ways the most important part of the slide, part of the presentation, if you're going to try to grasp what's happening globally, and it's the ambitions versus the actions. Okay? Is the strategy a statement of intentions, or is it a statement of what's actually happening? Okay? And this is a study that was done not too long ago, less than 2 years ago, just inside the EU, and you can see what the statements are in terms of what the intentions or ambitions are versus what they're actually doing. So we could say that part of Roger's presentation today was statements of intent, right? And we didn't push him on this because we didn't have the time, but we could have pushed him later and said, well, how firm is the commitment, the financial commitment for your next 13 years? Because he said it's going to take him 13 years, right? $100 million, and he's getting 40. How firm is that $40 or $50 million a year? He got it this year. How committed is it next year? Now, if it's still a question of getting approval every year, then part of his plan is intentions. And many of the national strategies are statements of intent, as opposed to necessarily statements of or what we're doing. Another major difficulty we have is we lack reliable data. It's very serious reliable data. There's a number of reports out and papers out talking about the limitations of our data internationally, and in part because of our semantic challenges that we have. Okay? And one of them is around the EHR. What exactly is meant by the EHR? There's still not, I don't think, 100% understanding and agreement in Canada as to what we mean by that term. Okay? There's sort of a general perception that we think we understand, but there's still some debate going on even in our country. What exactly do we mean by the EHR? One way of sort of reinforcing that is, okay, McDonald's is a restaurant, right? Well, so is a 3-star Michelin restaurant. They're both restaurants, but they're quite different, are they not? Okay? So that's the situation we have with the EHRs. We have some countries defining it one way, others defining it another way, and in some cases there's quite some variation. Just another report about the lack of reliable data. We just don't know, and we being, in a lot of cases, globally. We particularly don't know, we know best what's happening in primary care. The use of technology by physicians, by GPs, sorry, not by physicians, by GPs and family physicians. Okay? That's probably where we have the best global data, particularly in Europe. Next, is a big drop, huge drop, as to what's the status in hospitals. Big drop. It's to what's the status of hospitals. How can we say with any degree of reliability what's happening in hospitals? I mean, even in primary care. We heard, I think it was Dick said that Alberta's up to 50%. And then someone, I think, said, well, it's higher than that. Well, I just got an Alberta document 2 weeks ago that they asked me to comment on, and the number is indeed 50%. But they don't know how much of those 50% of physicians who have computers, no idea to what extent they're being used. No extent. Okay. They can speculate, they can do small little surveys, but they don't have a reliable way of keeping. So we do have, and then we start with primary care, we're best there. Then we're into hospitals, not very good. Huge gap in community, mental health, and those other areas. Just no data. This is a colleague from Germany who, when we were discussing this, he and I are trying to develop some kind of tool that's going to be able to somehow score countries in some fashion. And we've been working on it now for close to 2 years, and we don't think we're going to be able to do it because we can't find reliable data in which to base the measurements. Okay. So he's got a nice expression. Finding objective reality is very elusive. Okay, and then the other part, which is another aspect of it, which I did do, is the coverage. Okay, we've had many international studies. Well, not that many, some. Often they only talk about primary care. That seems to be the best place we can get some data. In a lot of cases, it's just a study which is reporting other studies, so it's nothing new. And in many cases, there's a lot of questionable methodology, particularly in terms of sample sizes and things of that nature. So here's some of the more recent studies. Even this one is coming out, should be out, it's supposed to be out by now, it's a little bit behind, is the European Union study, which is looking at the e-health strategies of all 27 European countries. And we were hoping it was going to be a part of that. We're hoping it was going to be a lot more quantitative and a lot more objective. It's unfortunately going to be quite subjective. Some of the countries we will have, the data which we will report is the opinion of one person. So that's, we will discuss country X based on the views of one person. Other cases, we at least have panels of 4 or 5, and it's consensus of 4 or 5 people. In a few cases, we've got even a broader consensus than that in terms of the government agrees that yes, this is an accurate representation of our situation. Professional associations agree and so on. But those are the exception. Most of them are in the databases of agreements about 1 or a few individuals. So it'll give us something, but it's not going to give us the kind of thing we were hoping. Okay, so let's start running through some of these countries. Again, some.
I have a
Yeah.
question. You are mentioning that having more quantitative studies and approach. Doesn't it cost more than the qualitative that we do when we have that much?
Oh, of course, of course.
Where they are gonna bring the money then?
European Union, I haven't seen the announcement, but I know that they were accepting proposals to fund a study that was going to look at the actual utilization of the technology by physicians, specifically by physicians in hospitals. And it was considered to be a large study. The large study meant they were going to look at 5 countries, and they were going to look at 1/20 of the hospitals in each country. That's all they had the money for. Okay? And in that, they were going to targeting to talk to 100 physicians. Even though that hospital may have 1,000 physicians working in it, there's only so much time and money that they have available. That study hasn't been released, which reminds me, I should find out as to who won that contract. Because I know that my name's in two competing groups competing for that particular research study.
You can bet they'll be talking to the biased physicians too.
Sorry?
They'll be talking to the biased physicians.
Hopefully they'll have a research design. Hopefully they'll have a research design that tries to minimize that. Absolutely, absolutely. Okay,